Hare Krishna, respected teacher, colleagues and mentees. I'm Dr. Manish, and it's my proud privilege to introduce the ISCCM for its journal club, which is happening for the first time. And it's a honest, heartful attempt by the Indian Society of Critical Care Medicine to organize the journal club, where we shall not only dissect and elucidate the journals of clinical relevance, but we shall also ponder and reflect its possible universal acceptability and applicability. We are here to simplify the evidence-based medicine to the bedside medicine, and this is being executed under the stewardship of our President-elect, Dr. Ranveer Singh Tyagi, sir. Sir, I welcome you. And of course, this project could not have taken its due shape and its outcome without the guidance of our President, Dr. Srinivasan Samvedam, who's a dear friend and a mentor. Professor Pradeep Kumar Bhattacharya, ISCCM past president. Thank you, sir, for your nuggets of wisdom, which I was able to share. Dr. Sachin Gupta, who is the General Secretary, ISCCM, and Dr. Ghanshyam, who is the General Secretary-elect. Now, my dear friends, for today's journal club, we have two papers which we are going to dissect and ponder. And of course, it is going to be done under the guidance of our expert, Professor Rakesh Garg. Now, Professor Rakesh Garg, he's not only an expert to this session, but also he's a great visionary when it comes to the research and methodology in this country. So before I introduce the speakers for today's session, Dr. Ranveer, would you like to share your insights, sir, for this mission which you have taken? Yeah, please, sir.
Thank you very much, Manish, for your kind introductions. And good evening and Radhe Radhe to Rakesh Garg boss and dear all friends and teachers who have joined this and all the students. So basically, purpose of this club is already Manish tell evidence based to bedside. So we are feeling a lot of problem only by the reading, but when we are working in the practical way, that is very difficult to detect. So we bring to both together evidence based in the bedside clinical practice. So that we started this, and I hope Dr. Manish and Neeraj, along with mentor Rakesh Garg and Pradeep and Srinivas all together, we try to achieve all higher which is possible to do for the student, for our patient, or for our colleagues. So that is the aim. So this journal club on every third 5 months, almost 12, then of president. Now I hand over mic to Dr. Manish and Dr. Neeraj. Please go ahead and take forward this. Thank you.
Thank you, sir. Thank you, Dr. Ranveer, sir, for your guidance and the vision. And of course, we have a responsibility for the next year to take it to the next level under the guidance of Professor Rakesh Garg, sir. So for the first paper, our speaker is going to be Professor Neeraj Kumar. And Dr. Neeraj Kumar is an associate professor in the Department of Anesthesiology and Intensive Care Medicine. He's at AIIMS Patna. He's also an executive member for ISCCM Patna branch. And not only this, Neeraj is going to be a co-moderator for all the sessions when it comes to the ISCCM Journal Club. The paper 2 or the journal 2 will be presented by a very close friend of mine, Dr. Arijit Sardar. He's an ex-alumni from All India Institute of Medical Science, New Delhi. Right now, he's a senior consultant and he's an expert in ECMO at Yatharth Group of Hospitals, New Delhi, NCR. So I would like to start from you, Dr. Neeraj, as far as the first paper is concerned. Please go ahead.
Okay, thank you. Let me share my presentation. So I think it's visible, slide?
Yes, it's visible, Neeraj.
Oh,
thank you.
Thank you. Thank you, Dr. Manish and Dr. Ranveer sir and Rakesh sir for this opportunity. And I think we will be discussing one interesting paper which has been just published in this month only, in the month of March. And the journal is the JAMA Network Open. Basically, it's an international peer-reviewed open access general medical journal, which is published online every day, means every weekday. And the current impact factor is 10.5. And this is the third highest ranking among the general medicine open access journal. The editor-in-chief is L.A.N. Perencevic. And the topic for the today's discussion or journal club presentation is original investigation, which is published in JAMA Network Open Surgery portion. And the title is Targeted Normoxemia and Supplemental Oxygen Free Days in Critically Injured Adult, a stepwise cluster randomized clinical trial. And the primary author or lead author is Dr. Doen, and the corresponding author is Dr. Ginde. This study has been carried out at University of Colorado School of Medicine, Colorado, USA, and this paper was published in March 31st. Now, coming to the conflict of interest and disclosures, Dr. Doen has reported receiving grants from National Heart, Lung and Blood Institute during the conduct of study. And Dr. Ginde also received a grant from Department of Defense, USA, and NIH and CDC, as well as Patient-Centered Outcome Research Institute. Now, coming to the virtual image or coming to a virtual abstract of this article, it's a randomized controlled trial in which targeted normoxemia and as well as supplemental oxygen free days in critically injured patients were basically taken care of. So a total population was 12,487 patients, and the study was conducted at 8 different centers of the US in level 1 trauma centers. And there were around 8,000 men and 3,600 women patients. The inclusion criteria were all those injured patients admitted to the surgical or trauma intensive care units within 24 hours after the hospital arrival. And the criteria for the admission was based on the injury severity scoring. And the mean age was 52 years. And there were two groups. The first group was patient with targeted normoxemia, which means encouraged to decrease in the supplemental oxygen if a patient maintains oxygen saturation of more than 96 in all ICU patients. And the second group was usual care, in which around 6,800 patients were given a usual care where the supplemental oxygen administration were determined by the treating clinicians. The important finding was that the randomization was crossover randomization from usual to targeted group normoxemia patients at every 3 months interval. And the primary outcome were supplemental oxygen free days through day 28, which is defined as the number of days alive or not receiving supplemental oxygen from the time of presentation to day 28. These were the Kaplan-Meier mortality curve, which we'll read later. Now, coming to the clinical question, they targeted that does targeting normoxemia safely increases the number of supplemental oxygen free days among critically injured patients or not? And the objective was to determine the safety and effectiveness of targeting normoxemia in critically ill trauma patients. Now, coming to the introduction, we all are aware that these critically ill patients commonly receive supplemental oxygen to enhance the tissue oxygen delivery to prevent the hypoxemia. But higher oxygen targets always provide a margin of safety against hypoxemia. Why? Because there is increased risk of exposure to excess FiO2 and hyperoxemia, which can lead to tissue damage as well as tissue inflammation. Now, excess oxygen supplementation is common in critically ill patients, but it may be logistical challenges, especially in resource limited settings. Now, conserving oxygen by safely reducing the use of supplemental oxygen can improve the logistics and can be useful in the setup, like in military areas where the war has been called off or war has been started, and where the resource limited situations you want more and more oxygen. Now, why this is important? Because supplemental oxygen is a fundamental to caring for critically injured patient, but can expose them to excess inspired oxygen. Now here, one observation studies was already published, which has associated with targeted normoxemia, where the peripheral oxygen saturation measured by the SpO2 were in a range of 90 to 96% or PO2 value of 60 to 100 millimeter of mercury. And they founded the correlation with improved clinical outcome among critically ill patients. Now, how they have done? previously they have done a single center pilot trial where they targeted normoxemia, and then they have seen that whether there is any decreased use of supplemental oxygen in critically ill trauma patient. But what they have not done before that, they have not compared the outcome, clinical outcome on targeting that normoxemia. That's why they conducted a strategy to avoid excessive oxygen trial to determine the safety and effectiveness of targeting normoxemia in critically ill patients. Now, the hypothesis of this trial was targeting normoxemia would safely reduce the exposure to hyperoxemia and increase in the number of days alive and without supplemental oxygen. So this was the main hypothesis for which this entire stepwise randomized control trial was best. Now, if you see in the method, it was a multi-centered stepwise cluster randomized clinical trial where this has been conducted at 8 level 1 trauma centers throughout the geographically distributed throughout the US. If you try to understand this this stepwise cluster randomized trial, what happens basically in these trials, that out of these 8 sites, the first month was kept for washout period, and the next, for every 3 months, in a step ladder approach, the intervention was crossed over. So means the pre-implementation control group were crossed to post-implementation intervention for every 3 months. So this was the 3 months duration, and then each step the crossover was randomized as 3 months interval. Now this the IRB approval has been taken from the Colorado, and site level randomization was also done to minimize the potential for contamination between the participants before admission and then after intervention was applied. And there were no existing protocol initially to promote a targeted normoxemia strategy. Now, coming to the population, that the study was started from July 15, 2020 to November 14, 2022, and trauma centers were randomized at every 3 months, and then they were crossed over from usual group to targeted normoxemia group. The inclusion criteria were, these were the inclusion criteria, and exclusion criteria were all those patients younger than 18 were excluded out. Pregnant, incarcerated patients were also excluded out. Now, coming to the intervention, what they have done, that trial intervention for targeted normoxemia by titrating supplemental oxygen in trauma patient in ICU receiving mechanical ventilation versus not receiving mechanical ventilation, they have done earlier. But based on the modified Delphi consensus approach, they defined the oxygenation based on the non-invasive SpO2 values into 4 different types, like hyperoxia when SpO2 was greater than 96, normoxia when SpO2 was between 90 to 96, and PO2 of 60 to 100, borderline SpO2 of 88 to 89, and hypoxia when SpO2 was less than 88%. Now, they were the 2 intervention group. The first were usual care group, where the supplemental oxygen was administered determined by the treaty clinicians, and targeted normoxemia group, in which they decreases the amount of supplemental oxygen when the patient exceeds the SpO2 of more than 96%. And the intervention was initiated immediately on patient arrival to emergency department. Now, they have made an oxygen protocol based on the SAVE O2 trial, that what I have discussed earlier. And in that, what they say is that the non-binding recommendation means when they have started down titration of the flow rate, when the patient was having a sustained hyperoxia, like SpO2 was more than 96 and PO2 was more than 100 for 30 minutes, to achieve a target SpO2 of 90 to 96%. And then the FiO2 titration in mechanically ventilated patients was titrated by 0.1%, and if the patient was non-mechanically ventilated, the titration was 1 to 2 liters per minute until normoxemia was achieved. Now, the same thing was that this trial protocol was directed based on the FiO2 and oxygen flow rate adjustment to the assigned SpO2 target during the patient index admission. And what they have done, that after patient who were discharged from the ICU or transferred from the floor bed, their oxygen titration was no longer a part of the protocol and was discretion of the clinician team only. They have collected data from the EHR and state trauma registries, and that repeated SpO2, PO2, FiO2 measurements were included, and all those patients who have not receiving the mechanical ventilator were converted to oxygen volume to FiO2 by adding every 3.5% for each liter per minute of the oxygen required, which were starting from 21% of the FiO2. Now coming to the outcome measures, they given the time zero for all outcomes for the patient time of arrival to the ED at each site, and primary outcome was supplemental oxygen free days through day 28. So they defined these supplemental oxygen free days means the number of patient who remains alive and not receiving supplemental oxygen from the time of hospital presentation to till day 28, and these were the secondary outcome like ventilatory free days to day 28, in hospital mortality to day 19, and then hospital free days to day 90. They have also given one more values that even the patient who died in the hospital death before 28 days, they received a value of 1 minus SOFD, which is consistent with the previous literature defining a worse death. Now coming to the other part, what they have also done, that they were not included any patient who were intubated and ventilated exclusively for surgical procedure and then extubated immediately on completion of the procedure. So they did not count the SOFD for calculation, and this SOFD means supplemental oxygen free days has been validated as an outcome in clinical trials. Now, if you'll see this Kalper-Meyer mortality curve, here what you'll see that there is a proportion of patient who remains alive and there is a proportion of patient who has not receiving supplemental oxygen through day 28. So there is a broader black line which is suggestive of targeted normoxemia group in the room air, and then the broad yellow line which is suggestive of usual care group of patient who remains alive on room air, and this was the Kalper-Meyer mortality plot, and the lower blue line was suggestive of your patient not receiving any supplemental oxygen. Now coming to the statistical analysis, they analyze based on the intention to treat approach by using a R core team version using 4.2.0. Now they performed a estimation using Cox proportional hazard regression model using a survival package in R, and two-sided like p-value equal to 0.05. They indicated it as a statistical significance. Now they previously used a pilot study, and they estimated that at 28 months of trial period, they included at least 6,000 patients enrolled for including in primary analysis. Now what they have done, they estimated the mean or standard deviation for supplemental oxygen free days, and they found that the mean value was 15.5 days, and making an intra-class correlation coefficient to achieve 0.04, they enrolled 6,000 patients, allowing or detecting a difference of SOFD between 1.4 days with a power of 80% to 90% power they want to achieve with a median days of 1.64 days. So keeping these alpha error of 0.005, they kept enrolling patients of around 6,000 in each group. So overall, they included 12,800 patients. Now coming to the primary analysis in statistical analysis, they compared the number of SOFD among the targeted normoxemia group versus usual care group using a linear mixed effect modeling. Now, linear mixed effect modeling is basically a robust system of statistical analysis in which they used to do this is based on two different variables like fixed variable and then your random variables. That's why, because they want a multiple time points data of a single individual, so they compared this. They use this model, linear mixed effect modeling, and they anticipated that there may exist some balances from the baseline values, like that's why they adjusted the model for age, sex, race, and ethnicity, and then other parameters like BMI, mechanism of injury, and then injury severity score as well. Now here also one more important point is race and ethnicity were self-reported by the patient, because considering the skin pigmentation in different race as well as different age group ethnicities. Now they also analyzed the secondary outcome like ventilator free days to 28 and hospital free days to 90 using the same linear mixed modeling approach similar to that what they have used in primary outcome, and they use that mixed effect logistic regression for all those dichotomous outcome, and then mixed effect ordinal logistic regression for all those ordinal outcome, like your Glasgow outcome score. And then time to event outcome, like time to room air, time to mortality, they used a Cox proportional hazard regression model. Now, this is the result. If you'll see in this diagram of comparing all those patient demography and injury. So the patients were in targeted normoxemia group, it was around 5,661, and in usual care group it was 6,826. The median age group in the both groups were 53.2 and 50.4, and the female patients were 29.2% in targeted normoxemia group, and in usual group it was 29.8. The male predominant were more, and the race and ethnicity, you can see that different races like ethnicity like Hispanics and non-Hispanics, black, white, and other races were also included. If you'll see the injury severity score here, the injury severity score was almost common in both the groups, as well as the initial GCS score was almost common by 12.1 to 11.7, and this was mainly due to the skin pigmentation that affect the pulse oximetry performance. That's why they have taken the self-reporting for race and ethnicity. Now coming to the study flow diagram, where you can see that 13,649 patients were screened at 8 different emergency department sites, and out of this 294 patients were excluded because of the missing data, and then based on the primary outcome, they analyzed 6,826 patients in the final analysis in both the groups. So if you'll see that result, they measured around 21 lakh SpO2 values between enrollment and ICU discharge among 12,487 patients, and median IQR SpO2 measurement per patient was approx 100, but in a range of 48 to 206, and proportion of ICU spent in the normoxemia group were increased from 56.2 in the usual care group to 71.6 in the targeted normoxemia group, and hyperoxemia, which is defined as FiO2 more than 21%, which is decreased by 42.4 in usual care, whereas it is further more decreased in the patient who were targeted normoxemia group in a ratio of 26.7%. And the hypoxemia was almost similar in both the groups, like targeted as well as in usual care group. If you see the mean FiO2 and oxygen saturation measured by the pulse oximetry, they represent that the patient time was considered a non-modifiable form, and it was the patient who was receiving the FiO2 of 21% and has a SpO2 of greater than 96%. So if you'll see the primary outcome of this study, the primary outcome was supplemental oxygen free days through day 28. And what they found, the raw mean SOFD through 28 days was greater in the targeted normoxemia group than usual care group, like from 96.6 days to 17.5 days. And if they on comparing the targeted normoxemia to usual group, what they found, it was the 3.32 days, and it was not very statistically significant. If on comparing the secondary outcome, they found that in hospital mortality to day 90 in 563 patients were 9.9 in the targeted normoxemia group, and 732 means 10.7% in the usual care group by getting a AHR adjusted hazard ratio of 1.105. Now these AHR means if the patient has a AHR in this study, the AHR more than 1 was not statistically significant, and they indicated that this targeted normoxemia has a mortality almost equal to what the usual care groups were receiving. Now coming to the discussion part, although among adult trauma patients targeting normoxemia did not significantly increase the number of SOFD, but they reduced the administration of supplemental oxygen without substantial increase in hypoxemia, death, or adverse events. Now, no difference in 90 days hospital mortality or hospital free days, but they observe a greater ventilator free days in the targeted normoxemia group. Now, what is the clinical implication? They found that among critically injured patients, targeting normoxemia can safely decrease use and expedite liberation from supplemental oxygen. And the previous studies also has a result that are consistent with the recent meta-analysis of around 13 RCTs, where they found that oxygen targets in critical ill patients is of benefit. And they also exclusively enrolled critically ill patient, trauma patient, which represented up to 14.5% of the patient in previous trial, focusing only on medical illness. But this trial, they included only traumatic brain injury patient, and they haven't focused only not on any medical illnesses. And the third part is, since the oxygen supply is limited in military and other auspicious settings, safely reducing the use of supplemental oxygen in critically ill trauma patient has logistical importance and its own advantage. And then coming to the strength of this study, this is one of the largest to date amongst trials which compared the oxygenation targets and allowing for more precise estimation of this treatment effect. And then they achieved the immediate implementation of intervention as soon as the patient arrived to the ED through the entire ICU stay. And then they enrolled the 8 different geographically demographically diverse site, enhancing the generalizability and clinical applicability of the trial results. And they embedded targeted normoxemia into usual care across many diverse sites, increase external validity of the findings. And then they used a stepwise randomized cluster design rather than patient level randomization, only to improve the generalizability and clinical applicability. And in addition to adjusting the patient level covariates or temporal trends, they usually captured a site specific random effect to adjusted model to capture the site heterogeneity. Now coming to the limitation of this study, although they have done a washout period of 1 month run period, which was provided between both the groups, like usual care and targeted normoxemia patient, for clinical staff to master the implementation of targeted normoxemia or adherence to the protocol. But this protocol adherence may be varied throughout the targeted normoxemia at each site, and then there may be a reduced separation between the groups of SpO2 and FiO2. So this was one of the limitation. The second limitation was achieving 100% of the patient time in normoxemia among target normoxemia group would have been ideal, but it is impractical to achieve, and this was one of the limitation in this pragmatic trial. And they also have given one limitation, that if this trial was conducted during the peak period of COVID-19 pandemic, they may have altered the implementation of the intervention and associated results. And in this trial, they assessed the patient only who were in the in-hospital outcome they have monitored. They have means up to 90 days. They have not monitored any post-discharge or any long-term outcome. And they did not control any additional interventions like ventilatory management. And that's why conclusion, in this randomized control trial, targeted normoxemia did not increase the number of supplemental oxygen free days among critically ill patients, but it safely reduced the supplemental oxygen use without an associated increase in hypoxemia or any adverse events. And targeted normoxemia appeared to increase the number of supplemental oxygen free days among critically ill trauma patients not receiving mechanical ventilation. So this is all about from my side, and I think Rakesh sir, we can have a discussion of critical appraisal at this point of time.
Perfect. Yeah. Thank you so much, Dr. Iris. Interesting article. So when we have papers like this, there are two aspects to see the paper when we want to bring some change into a clinical practice. One, we have to see whether the paper is coming from a good place and the authors are reliable, and what type of journal it is, because nowadays we also talk about journals which has good reputations, and we have to look for it. And Dr. Neeraj mentioned about the journal aspect. So journal is a good journal, appears to be a peer-reviewed journal, and peer-reviewed means that this article has been scrutinized by the reviewers and the editors before they are published into the study. Second aspect is when we see this paper, we have to see whether the outcome or whatever this data which they have given to us from this study, whether I can bring it into my clinical practice. So I have to compare everything into my clinical practice. There will be a good number of papers. I will just give you one example. I'll go into detail subsequently. So they have mentioned about, say, for example, in this paper, this supplemental oxygen was only for trauma patients.
Yes.
And if we see the number of patients and if we see the author's affiliation, they were coming from the military aspect. So this means the catchment population, which was covered in this population, I will ask Dr. Neeraj to clarify, that the catchment population was civilians with a road traffic accident coming with trauma, or they were military peoples who were living in a campus with a very structured rules and regulations, and then they're coming for trauma. And whether that type of trauma, that type of mechanism of injury is similar into my aspect. Say if I stay in Delhi and I'm taking care of the South Delhi aspect, I will see that the pedestrians are more commonly injured coming to our trauma center, which requires oxygen supplementation. So this is I'm just giving an example. We will come step by step when we look for that. When we see the paper, we just cannot say that they have used oxygen and they have found that it's not useful, and in low resource settings, we can start using it. But it may be a little different from our population. I've just given a simple example. Second example will be if I say that in Delhi or in Patna or in any aspect of the NCR area, the trauma victims are they taken care and provided first aid on the spot? We have to see in this country. Or if they are brought as a critically ill patients by the layperson, once they have a blood loss of say half a liter, 1 liter, 1.5 liter, though they have mentioned somewhere in the injury severity score, but the timing they have not exactly mentioned at what point of time and what preoperative pre-hospital care has been given to these patients. So this will also differ. So a patient who comes to my trauma center with a blood loss of say 20% or 25%, or maybe you can say, depending upon the hemorrhage, the oxygen requirement and its benefit will be much more as compared to a patient who comes to a trauma center by a trained paramedics who has taken care of hemorrhage control in the field, secured the intravenous access, and has given some fluid. So that's why when we see this paper, this is 2 examples I have shown, that when we try to extrapolate the findings of a study to my clinical practice, we have to see both the aspects. And this is the basic purpose of General Club, to understand that what are we going to study for this. So I think we will have some dialogues with Dr. Neeraj. He has mentioned it, but since many of us are listening, I will just take you through some dialogues so that you can understand that when we see the paper, what we should look into the paper before we start accepting into our clinical practice. Yeah. Dr. Neeraj, my first question to you. Did the study addresses a clearly formulated research question? Because it's an RCT. They have clearly mentioned a PICOT-based research question into the study.
Yes.
So can you just...
Sir, basically, they if you'll see about the PICOT, I don't think so that they have added the PICOT, because they have not mentioned which population. They have mentioned a critically injured adult patient, and then if you'll see about the population intervention, they have intervention written, the intervention. They have monitored the outcome also, because they want to see the supplemental oxygen free days as a primary outcome. So I think population, intervention, and control has been there, because the control is not mentioned, because they have mentioned here intervention as a targeted normoxemia group, and for control the usual care groups was there. So for perfect PICOT, I think 3 findings need to be there, which is there in this article. Sir, first point.
Right. So this means if we see the paper, the full paper is in front of me. So though they have mentioned somewhere in the beginning, but if we see there in the introduction section, the straightforward research question is not very clear that which are going to be included. But if you go down and try to look for the population aspect, they do mention that the criteria for entry into state or national trauma registries and were admitted to surgical or trauma ICU within 24 hours of arrival at a participating hospital.
Yes.
And they have taken up 8 hospitals. So this was within 24 hours, the patient was recruited once they have presented to surgical or trauma ICUs. Yes. But they have not mentioned that which are these group of patients. Have they included everything? Only they have mentioned that younger than 18 years, pregnant.
They have excluded out. Yes.
Incarcerated or transferred from another hospital, they have excluded.
Yes.
So when we say if something is transferred coming to the hospital, and if we see an Indian population, so probably if we say that the level 1 care is being provided as a first aid and they have excluded it, So probably if somebody is working where a patient receives a first aid and then goes to the ICUs, so those data is not there into the study. So whatever outcomes we are going to apply will not be applicable. It will be only applicable wherein the patients are directly coming to their trauma or surgical ICU within 24 hours and they have not received or transferred from another hospital. So this is one situation which can be seen into our hospitals, that usually they are critically ill patients. They are given the first aid, especially the trauma patients, in the nearest hospital, because police will take them to the nearest hospital and then they are given a first aid and then they are transferred to the other hospital. So this data is not there. So we are not very sure that when we start applying this oxygen supplementation to achieve normoxemia, this data will not be applicable to that particular group of population where they are transferred. So they are excluded.
That's why, sir, they have kept that median age group of 52 years. And if you'll see in the demographic data also, sir, that what you are talking about, the ethnicity or the whether they were from military base or not, they were not from any military area, sir, because they were various Indians also, non-African, non-Americans also were there. But mostly it was done near to that same geography of that Colorado. And then all those level 1 trauma centers where they have written. I don't know why, because they have not written that why they have omitted all those young patient means lesser than 18 years of age. But if you see the injury severity scoring as well as GCS, the arrival GCS, median arrival GCS was 11 and 12 in almost both the groups, as well as injury severity scoring, because the ISS used to cover between 10 to 25. The more score will be there, more severity will be there. So here the severity ISS score between both the groups were near to 10 or 12. So they have taken more or less more stable patients, I think, and then they have they analyze that outcome. Only one thing that I want to mention here, sir, that all those their primary outcome is to measure the supplemental oxygen free days, in which in this trial they were not able to achieve that. So maybe because of that limitation, I think this study is not very means clinically practical. But only one thing is that even if we can target this normoxemia,
we'll come to this point little later, because before we reach, we'll come a little later about that. How can we extrapolate this to our population? I'll come a little later.
Yes, sir.
So this is what you mentioned about the pediatric versus elderly. So I think that point is clear, because they were taking into trauma ICUs, and we understand that pediatric trauma ICUs are separate one, and they have different ways of scoring and resuscitation fluids.
Yes.
So that's why probably it's okay to keep them separate, and they have taken on the surgical and trauma ICUs. And as per norms, even for India, anybody less than 18 years or less than 14 years or till the signs of puberty, they have been taken care by pediatrics, and they have different regimes. Even the fluid regime is a little different. So when we say fluid regimes are different for adults versus pediatric population, we understand that the oxygenation aspect is directly related to the perfusion. So when we have different fluid management, different blood volumes, so this means perfusion may not be comparable, and they were right in that extent that they have not included into those patients, so that bias with regards to the physiology of the patient would be a little different. So next question, let's see this paper once again. So we see that PICOT is not mentioned clearly, but it appears to be divided into various aspects. So if we see population studied, they have mentioned it. We just discussed about the population. When we say the multi-ethnicity, now, Dr. Neeraj, do you think that when we say multi-ethnicity and they were maintaining the saturation, the pulse oximeter, if we say have blacks versus whites, the type of pulse oximeter will give different readings. And we know that pulse oximeters are affected by the skin color.
Yes.
So when they have looked for different ethnicity, they have used Asians, Africans, and all the population. And the primary outcome measurement tool was measuring this SpO2. Do you think it would have effect on, say, there was non-Hispanic blacks also and non-Hispanic whites also? So have they sometimes have looked after those aspects, and whether they were compared to our Indian population regarding because it's related directly to the primary outcome?
Sir, what they have done, sir, they have categorized their different means you are seeing that different race and ethnicity were there, but they have also included others races like American Indian and the Alaska Natives, Asians and all. But sir, they have not mentioned. What they have mentioned that they have given the patient that you have to obtain means their self-reporting SpO2 values were there, and they have written it very clearly that self-reporting only because what they feel that based on the skin pigmentation of various races the SpO2 is going to get affected. That's why they relied on the patient only, that patient will tell the SpO2 value and it will be recorded into the EHR, and then it is again one of the limiting factor. I think this is what I feel also in the study.
So again, this is because I was just going through the paper in front of me. So when we say we have to see for the primary outcome, which was primarily being measured using pulse oximeter, they have not mentioned anything about the type of pulse oximeter they are using. So when we say pulse oximeter, it is a Masimo technology, low perfusion technique, high perfusion technique, which say, for example, Masimos will take care of low perfusion and color aspects. And
they have not mentioned. They have not mentioned, sir. Even in the limitation, they have not mentioned. Yes.
Yeah. So this again, so we have to be a little cautious that whether it will be applicable to our patients or not, because if we think that non-Hispanic blacks are similar to us, we can take a hand. But I do not know because we are also mixed up. But again, it should be very clear that in trauma patients, it's very clear that low perfusion pulse oximeter has to be used when we are measuring it as a primary outcome. Perfect. Now, the other aspect is if you see was the assignment of participants to the interventions randomized? You rightly mentioned they were cluster randomization.
Yes.
And they have used a special techniques wherein it is very well applicable to our Indian population. This technique is because, say, for example, Dr. Manish Bharti wants to bring a change from Monday morning to do supplement oxygen to all the patients at one point of time. Logistically, it may not be a problem because we have to train everybody. And then what we do is we have to have a step-based pattern, which Dr. Neeraj has explained it. So we have to take it in a correct way. And this is the right way of choosing the study design. So the study design appears to be okay here. Only thing is when we say crossover, so at what point they were looking for the crossover? So it was regarding the centers.
3 months. 3 months period, sir. They were doing crossovers, which I have already explained here, that every 3 months, the pre-implementation group were going into a post-implementation and post-implementation were coming to pre-implementation. So that usual group and targeted group were crossing over. And they kept 1 month period for training for adherence to that protocol, which they have mentioned in their limitation also, that maybe 1 month or strict adherence to their oxygen protocol may be difficult to achieve. Yes, this is one of the...
Right. So we have to understand here, so when we say the crossover studies, the wash-in period should be appropriate. So when we have big ICUs, when we have a big staff, have we trained everybody to give these required protocols, which probably they would have done it. So we should be cautious in looking for those, whether the crossover had a sufficient wash-in period. Wash-in period simply means that when we have given some intervention to a particular group of patients, whether it's a drug, whether it is a strategy, whether it is a plan, it is totally washed off from the other aspects. So this is important. This is good for drugs because drugs goes away. But when we say training aspect, it becomes a limitation because when we train the person, we cannot say that get your gray cells off the previous technique and use a new technique. And it becomes that they may not be totally able to look for the new technique in these situations. And probably, Dr. Manish, whenever we are over the time, stop you.
No, I was not intent to stop you, but I think Dr. Arijit is getting impatient and he's also waiting to be mentored by you.
So, no issue. So I think I'll summarize in the next 5 minutes. Please. I think we'll take it this way and Arijit will simultaneously do the thing. Right. So this is what wash-in period should be clear when we present it. That wash-in period should clearly mention that how they were able to look for that the intervention they started, the pre-implementation, post-implementation, how they have come to the pre-implementation phase. Blinding is a big issue in this study because blinding, but then we say that they have done with EMR, so probably it should be okay. So we are okay with those blinding aspects. bias, there appears to be many bias. Paper, they have not mentioned clearly many aspects, but it appears to be okay. I think there are many things. It will take me half an hour, but I think we'll stop. This is just a beginning.
Actually, Rakesh sir, it's a big paper, but
Neeraj, I
but
just
we
have two clinical
Dr. Arijit
questions.
also. We have combined two papers for
No
the
issues.
So
Sir, I just have two
yeah.
quick questions for you, Dr. Rakesh. One, as far as the method of oxygenation is considered, they have been talking about by giving through the nasal prongs, or the patient is on mechanical ventilation, reducing by 0.1 fraction. Surprisingly, they have not included NIV HFNC.
Yes.
So those kind of a strategy, which otherwise becomes by and large parcel for the patients to be winning. Any specific reason what you think that, because generally when it comes to the oxygenation ventilation, these are all the tools if you put them in the correct armamentarium. So what could be the plausible reason? I was not able to understand.
So the possible is in trauma issues, this is a normal dictum that we don't provide them positive pressure ventilation, not even the HFNCs, because a small subtle injuries to the lungs can lead to tension pneumothorax in these patients. So they are usually on spontaneously breathing patients, and nasal prongs are usually accepted. NIVs for trauma victim patients in first 24 hours, it's not given because a small, simple rent into the lungs can become simple pneumothorax in the beginning and then tension pneumothorax. So that's usually the reason that they are not supplemented on high flows with HFNC. Number two, this study appears to be pre-COVID area, and at that time, HFNC was not very common.
I think that is what,
maybe the other reasons.
That should be the reason, because otherwise, we tend to give positive pressure ventilation, especially for the trauma cases who have an atelectasis tend to be there, especially. By and large, Neeraj, what kind of a trauma cases they have included? What is specifically
actually,
trauma?
boss, what they have done, they have included that penetrating trauma, right? They have included penetrating trauma, but I was reading very closely. They have not mentioned the exact injury.
Kind of a trauma profile.
But they have included only the, one thing they want to focus, that they have not included any patient having a medical illness, but they have focused only the patient with some forms of trauma. They have not mentioned that how much head injuries and all.
What about traumatic brain injury? Was it included?
Yeah, they have included traumatic brain injuries also, because their GCS at the time of taking those patients were in a range of 11, 12, like that.
Okay. Thank you, Dr. Garg. Thank you, Neeraj, for extraordinary conduct. So I would quickly go to Dr. Arijit for his presentation, and of course, Dr. Rakesh for his mentorship for the session as well. In the interest of time, we have to reduce because we are already 7:45. We have just 20 minutes left. So Arijit, it's a tough task.
Yeah.
Wish you all the best. Thank you.
Dr. Neeraj, can you stop sharing so that I can share my screen? Is it visible?
You are visible. Your presentation is not visible.
Okay.
Share your slide, I think. Yeah, now it's started to come. Yeah, visible.
Okay.
Make it full screen, Arijit. Make it full screen, please. Yeah, thank you. Excellent.
Okay. Thank you, Dr. Ranbir, Dr. Rakesh, Dr. Manish, and Dr. Neeraj for giving me the opportunity. So I'll not waste time. So the second study for tonight is biomarker-guided antibiotic duration for hospitalized patient with suspected sepsis. So this study was done in 41 centers in United Kingdom, spread across England and Scotland. And the main center for this study was Manchester University Hospital, and Paul Dark is the lead principal investigator for this study. So this study was published in JAMA 2024 in December. So without wasting time, I will continue with the study. So this study actually tried to prove that if you guide your antibiotic therapy based on your biomarkers, then that might reduce the duration of the biomarker. So as we all know that PCTs and CRPs, they are both inflammatory biomarker. And if you discontinue your antibiotic therapy based on PCTs and CRP, that can actually decrease the duration of antibiotic therapy vis-a-vis if you compared with the standard therapy. These are the few trials which has been done previously, and they are good trials, and they have also tried to address the same issues. Like if you try to de-escalate antibiotic on the basis of PCT and CRP, either you will have a duration of the antibiotic exposure or you will have little bit of mortality benefit. And based on these trials, there are a lot of meta-analysis in the literature. I would just mention 3-4 meta-analysis which have also tried to address the same thing. And everyone has come to the conclusion, which is something like that. If you have done antibiotic de-escalation based on your PCTs and CRPs, then it will reduce the duration somewhere around 1.5 to 2 days. And in some studies, there will be some form of mortality benefit. And probably based on this literature surviving sepsis campaign in 2021, they have given little bit of recommendation on procalcitonin, but not on CRP. So this recommendation, they have given recommendation both for starting the antibiotic based on procalcitonin and as well as for discontinuation antibiotic based on procalcitonin. So for starting of antibiotic, they have said for adults with suspected sepsis or septic shock, we suggest against using procalcitonin plus clinical evaluation to decide when to start antimicrobials as compared to clinical evaluation. So they are basically trying to say that do not use procalcitonin to start your antibiotics. You should only rely on your clinical evaluation. But for discontinuation, they have said you can use procalcitonin and your clinical judgment for the de-escalation or discontinuation of the antibiotic. Now, for the second part, for the de-escalation of antibiotic based on the procalcitonin, the main problem is that the quality of evidence is very low and most of the studies has been done in a single center with a small sample size. So that's why to mitigate this problem, this ADAPT study was planned, which was a multi-centric trial, and they have tried to include very large number of population to have a positive effect. So this was a investigator-initiated randomized controlled trial, which was done in 41 centers of NHS spread across England and Scotland. The study was started somewhere in 2017 and 18, and they thought they will be able to complete the study in next 3 years. But because of the COVID, they had to pause the study in between for almost 2.5 years. And then ultimately they have completed and published the study somewhere at the end of 2024. So coming to the inclusion criteria, they have taken everyone with more than 18 years of age. Obviously, they have to have a suspected sepsis and they have to have get some antibiotic, but the antibiotic type and duration will be at the discretion of the primary physician. Those patients were included whose antibiotic were initiated within 24 hours, and it was thought that those patients will be included whose likely antibiotic duration will be at least 72 hours. And within 24 hours of the recruitment of the patient in the study population, they have done the baseline biomarkers. Exclusion criteria, so prolonged antibiotic therapy, more than 21 days excluded from the studies. Any immunocompromised patient, but this has to be other than sepsis, has been excluded. If the patients will be expected to receive some IL-6 blocker in the form of tocilizumab and sarilumab, they have been excluded. If the duration of antibiotic therapy is less than 24 hours because of the futility, if someone has declined, someone hasn't given consent, or if someone has previously participated in these studies, they have been excluded from the study. Now, it was a 1:1:1 randomization into 3 groups, either standard group or PCT group or CRP group. Randomization has been done by a computer generated sequence number. Allocation was concealed by a centralized 24-hour web-based system, which was somewhere in Warwick control unit. And randomization was conducted by a site research staff. So for each and every 41 center, they had appointed one research nurse, or it might be research doctor, who were controlling everything. So what are the interventions they have done? So every day blood has been drawn for biomarker study. So what are these 2 biomarkers, PCTs and CRPs? And in the standard care group, they haven't done any testing. And they have continued until antibiotic discontinuation or discharge. Daily standardized written advised was being generated on a web-based automated system, and it would be either standard care or on the basis of biomarker guided antibiotic de-escalation. So in the standard care group, there is no recommendation from the study group, but in the biomarker guided group, they will tell either to continue your antibiotic or they will tell to discontinue your antibiotic. So in the standard care, they have followed some sepsis guideline, which was led by NHS England and FICUM. And the intervention phase is continued until the antibiotic de-escalation, or if they are voluntarily withdrawn from the study, or if the patient have died. And then after the intervention, there is something called follow-up phase. When daily blood collection sampling actually stopped, they have started follow-up these patients for adverse effect, for hospital discharge, for ICU discharge, all those kind of secondary data. Right. So the most important thing is PCT could not be measured at physician's discretion. So if you think you want to measure PCT in any of the patient, you are not allowed to do, because antibiotic de-escalation is based on PCT. But surprisingly, they could measure CRP, but this value of the CRP will not guide the physician for antibiotic related decisions. So you can measure CRP, but then your interpretation of CRP should be for other purpose, not for antibiotic de-escalation. The treating physician, they used to assess clinical parameters daily, along with that microbiological data, and the feedback used to be given to the research team, and documented decision then again will come from the research team to the primary decision for the decision of the either continuation of antibiotic or de-escalation of the antibiotic. Right? In the outcome, there are two primary outcomes. So the main outcome is total antibiotic duration from randomization to 28 days. And the second primary outcome is basically a safety outcome. So they try to make it is a non-inferiority trial. So they are basically trying to say that if you have done antibiotic de-escalation based on your PCT on CRP, then there is no mortality difference between the primary group and the biomarker guided group and the standard group. In the secondary outcomes, there are a whole lot list, but the main thing I think is antibiotic duration for the initial sepsis period, then the dose of the antibiotic, total antibiotic dose, unscheduled escalation of care, infection relapse, suspected antibiotic adverse reaction, time to fit from hospital discharge, critical care unit length of stay or hospital length of stay, and all-cause mortality. Statistical analysis, a bit complicated. I try to make it simple. So from NHS public data, NHS public and NHS health data, they have found that in UK, the mean average duration of antibiotic exposure is somewhere 7 ± 6 days. And based on from one meta-analysis, which I have mentioned in right bottom corner, they have found out that if you have done antibiotic de-escalation based on your procalcitonin and CRP, they to detect a mean difference of 1 day reduction in your antibiotic duration. So based on these two data, mean antibiotic duration and reduction of 1 day duration, they have calculated a sample size which is somewhere like 2,760 to have a positive p-value from this trial. And the secondary outcome, the second primary outcome for this study was a non-inferiority analysis, which is again taken from another study, which I have mentioned in the left-hand corner in the bottom. So this study tells if you want to have a non-inferiority trial on antibiotic related studies, then you should have a safety margin of somewhere around 5.4%, which they have taken into the analysis. And then it was an intention to treat approach. Each intervention arm has been compared with the standard care, but there was no comparison between the PCT and CRP group. For the primary outcome, which is the duration of the antibiotic, they have used logistic regression model to adjust for the confounders. But for the safety outcome, which is supposed to be the non-inferiority trial, there was no adjustment for the confounders. And total duration of the antibiotic therapy was analyzed in Kaplan-Meier curve, and they have used Stata 18 version for the statistical analysis. So coming to the result, this is the concert diagram where they have included around 16,000 patients, and ultimately 2,760 patients has been randomized into 3 groups. But a more important thing is that this parameters. So if the PCT value in the PCT arm, if the PCT value is less than 0.25, the primary clinicians were instructed to stop the antibiotic. If the PCT value is somewhere between 0.25 and 0.5, along with that, if the PCT has fallen more than 80%, then also they were instructed to stop antibiotic. And for the other cases, it is usual care. You can continue your antibiotic. In the CRP group, if the CRP value is less than 25, then you are supposed to stop your antibiotic. Or if the CRP has fallen more than 50%, then also you should be stopping your antibiotic. In the usual care group, there was no such advice. Coming to the demographic data, I think all demographic parameters, they are equally distributed in all the groups, but I should just mention few parameters. Almost 60% of the population were male and around 60% were the medical patients. Somewhere around 60% patient came to the ICU from the emergency department, and community acquired infections were the majority, and they constitute around 70%. Obviously, respiratory tract is the major source of infection in all the 3 groups, and they were able to detect almost in 50% cases what is the causative organism. In 50% cases, patient has gone into the septic shock, and the baseline SOFA and Apache score is high, and it is equally distributed in all the groups. They haven't never mentioned how they have screened the patient into the sepsis. That was on the discretion of the primary physician, but definitely they have measured baseline SOFA and Apache. So coming to the outcomes, so in the primary outcome, the primary parameter is the effectiveness study. So the total antibiotic treatment duration to 28 days. As we can see in the PCT group, it is 9.8 days, and daily CRP group, it is 10.6, and standard care, it is 10.7. And when you have done in intergroup comparison, standard care versus PCT care, this data is statistically significant, but this data is not significant if you compare between standard care and the CRP group. The safety margin outcome, the 28-day all-cause mortality, it was supposed to be a non-inferiority trial. And in both the cases, it is non-inferior if you compare between the standard care and the PCT group, or if you compare between the standard care in the CRP group. In the secondary analysis, there is one parameter which is called antibiotic treatment duration for the initial sepsis period. For this parameter, again, the data, if you compare between the standard group and the PCT group, it is statistically significant. And the data is again statistically significant for standard group versus CRP group. So I would just like to mention to grab attention of the reviewer. For PCT group, the antibiotic treatment duration for initial sepsis period is significant, and antibiotic treatment duration for 28 days is also significant. But in between standard and CRP group, the antibiotic treatment duration for initial sepsis period, this data is only significant, but when it is extrapolated up to 28 days, this data is not significant. The other secondary outcome like the antibiotic dose duration, unscheduled care of admission, number of patients with adverse event, time to discharge from the hospital, time to discharge from the ICU, and infection relapse, they were equally distributed in all the groups, and data are not statistically significant. So this is the Kaplan-Meier curve. So the first one is the probability total antibiotic duration for 28 days, which is the primary effective outcome. The lower blue line is PCT guided group, and the upper the indigo line is basically standard care, and you can see there is a difference margin between these two lines, and it is statistically significant. But when you compare between the standard care and CRP care, which is a red line, the data is not statistically significant. And when you compare the safety outcome, which is basically the non-inferiority trial, none of the data is statistically significant. So in the discussion, in the primary outcome, PCT versus standard care. So there is reduction in total antibiotic duration, and it is non-inferior for 28 days all-cause mortality. So the primary safety outcome has also been met. But if you compare between CRP and standard care, there is no reduction in antibiotic duration, and this study is inconclusive for inferiority trial for CRP group. In the secondary outcome, antibiotic duration for initial sepsis period, both PCTs and CRP protocol performed better compared to standard protocol, and the data is statistically significant. So the reason for the CRP protocol, the antibiotic duration is significant for the initial sepsis period, but it is not present up to 28 days period. So they have tried to give the explanation for this. So they have said CRP takes longer time to normalize than PCT, which has actually made the prolongation of the antibiotic duration, and that's why there is no difference between the standard care group and CRP group. Coming to the strength and the limitation, this is a very large multicentric trial which is spread across almost 41 centers in different parts of the UK. There was good intervention concealment strategy. There was a site research nurse who tried to do all the intervention without involvement of the primary team. There was very transparent documentation, and majority of the patient met sepsis 3 criteria for the inclusion, as they all have very baseline high SOFA and Apache score. Coming to the limitation, the concealment strategy could have led clinician to stop antibiotic later. So basically the primary team, they were waiting for the return of the stop advice from the research team. This might have actually prolonged the antibiotic duration. There was a shared environment for all the protocols. So in the same ICU, 3 different patients were under 3 different protocols. So that might have led a different result. Allowing CRP measurement outside the protocol, this also might have impacted the result. And there was no comparison between CRP and PCT group. So my take-home message is that this studies has actually emphasized that PCT-based antibiotic discontinuation protocol may be a safe and effective way of reducing the duration of antibiotics in critically unwell patients with suspected sepsis. But I would definitely love to have a comparison between PCT and CRP protocol, because CRP is much cheaper and easily available, especially in third world countries. And there should have been a cost-effective analysis in this study. So thank you guys for giving me my time.
Thank you. Thank you. We all will keep calm and we will trust on PCT. So Dr. Rakesh, your quick snippets as far as the understanding for this presentation is concerned.
I think this is a good study, and many of the things has been mentioned clearly. My only question will be when you are comparing the primary outcomes, it was a 3-arm study. In the 3-arm, the sample size you mentioned in the beginning, with the reduction of 1 day as the acceptable beneficial effect. So that sample size was done for 3 arms. But when we compare it, they have compared PCT separately with usual care and CRP with usual care. So this becomes underpowered then. So it would be difficult to say that actually PCT was giving him some difference in the outcome measures when you compare groups. So this is a message again that when we try to do analysis for a study, let it be a 2-arm study, then PCT versus usual care, and then CRP versus usual care. And third study could be PCT versus CRP.
Yes.
So when we take 2 modalities of titrating a drug, in case modalities here is PCT and CRP levels, and the modality intervention is the antibiotics, stopping or continuing it. So the sample size has to be appropriately calculated. So I'm a little concerned that even the conclusion that mentioned that PCT is shade better as compared to other drugs may not be coming from this analysis unless they have looked for the sample size for that aspects also. And obviously they have mentioned the limitations. So that is again the additional limitations. I couldn't see in the slides that because antibiotics usage may not only be decided based on these aspects, CRP level and procalcitonin levels. Probably were there some other parameters that was taken into consideration for weaning of the antibiotics or de-escalation or escalation of antibiotics, number 1. Number two, whether at any point of time there was a protocol of excluding patients who are immunocompromised. Number two, whether there was a comparison of use of steroids in any form, pre-incidence, that is pre-incidence of sepsis, or during the sepsis protocol. So are they compared, they are balanced in all the groups, or they are not shown?
So they haven't spoken anything about steroid. No mention about use of steroid. That's number one, sir. Number two, how they have decided to stop antibiotics. So is it only procalcitonin or CRP based, or they have considered clinical data also? Yes, they have considered both. So each and every day, the primary physician is supposed to record the clinical parameters of the patient along with the microbiological data. And then those data have been sent by the research nurse to the study group. And then the study group, they used to analyze these data along with the PCT or CRP value. And based on that, they used to say either you continue the antibiotic or you discontinue the antibiotic.
So this means the intervention was not primarily based on PCT.
No,
so
definitely not.
So our conclusion can also not be that PCT is the modality of choice for taking decision on stopping the antibiotics.
So the protocol was something like that. I have already mentioned. So if the PCT value is less than 0.25, so
yeah, you mentioned.
Yeah.
That table was very clear.
Right,
so what
sir.
I mean to say is your table was very clear, and they have made the nice form that when they want to take a chance and they want to stop it. What
Right,
I mean
sir.
is that when we conclude something, the authors want to conclude from this study, it has to be that the antibiotic protocol of discontinuation or continuing would depend on a combination of factors.
Right, sir. Right.
And
So I would say, sir, they have said definitely the primary physician group, they have sent back the data of the clinical parameters of the patient plus the microbiological data. And that has been considered by the research team along with the PCT's value. But when we are coming to the discontinuation of the discontinuation antibiotic based on PCT and CRP value, probably at that point of time, if they have considered the clinical parameter or not, that is not clear from the study.
Exactly. So even discontinuation may consider those clinical parameters, because sometimes you say not at 7 days, but probably another 3 days or 10 days you want to give it, especially when we talk about immunocompromised patients,
Right.
which is not very clear. So that will give us a better understanding of the various aspects.
Right.
Was there some protocol breach into these things? Because you said that they were being done in the same ICUs with different antibiotics protocols.
So not as such protocol breach. So they were tried to not to include COVID patients and viral infection patients. But
Right.
in spite of that, there were few patients who had both the infections. So they already had some bacterial infection and they also have some COVID infection vis-a-vis side by side. So they didn't get admitted in the hospital because of COVID. So they got admitted because of some bacterial infection, and incidentally they found they have some viral infection as well. So those, I think it's a very minor population. It's less than 50 total number of patients who had double infection or triple infection, but they haven't removed them from the study. Second thing is there was not as such protocol violation, but there were very few patients who have actually told we don't want to participate in the study for the entire 28-day duration. So they have been excluded from the study.
So I think I will not comment upon the other critical appraisal aspect, because it will take me half an hour, and Manish is looking towards me.
No, sir.
8:12 here. So I think that we'll consider next time that how to look for that, whether this data is applicable to our Indian ICUs. So that is what we need to look for. And when we say these type of studies, so when they come up, this study was from which place, Dr. Sada?
Sir, UK.
NHS. UK
41
NHS.
centers.
41
in
centers
NHS.
in NHS UK.
So if you say the NHS population, they will be referred by GPs, they will go to the centers, and there will be some waiting
Right.
period.
Right.
And the first dose of antibiotics are not given within 24 hours to these patients when we talk about the NHS. So that discrepancy.
That's the reality, sir.
That's a reality. I know sometimes even in 72 hours. So
Yes.
when we want to interpret this, so this is because many listeners are here. So when we want to interpret, we have to look these aspects also.
Right,
Because
sir.
at
Just
times,
just one comment, sir.
yeah,
So they tactfully avoided when the patient have actually got antibiotic after the diagnosis of sepsis, but what they have said, they have taken baseline blood samples for CRP and PCT within 24 hours, 4 hours of giving antibiotic. So
I agree. I mean, the CRP levels 20 times is not the double of 10 times. So the
right,
patient presentation will be altogether different.
right,
So this is what, when we interpret this data, we need to look for these aspects also, whether we can translate. So what I will conclude from this study is that probably PCT appears to be one of the component of the decision making while deciding the antibiotics discontinuation. So I will not say PCT is the marker, but I will say it's one of the deciding factor that should be considered while taking a decision for
right, sir.
the purpose of discontinuation or, I mean,
Yes, yes, sir. Sir, just I want to add something. So
yeah.
basically, there are so many false positive for PCTs. So there are other things like trauma, burn, major surgeries, some cancer, and even giving some anti-cancer drugs can give you positive PCT result. So just relying on PCTs blindly probably is not the best idea. So you have to have your clinical parameter, and then if you combine that with the de-escalation of the antibiotic based on the PCT value, I think that would be the right thing to do.
I think that's the reason for critical appraisal, because when we say what was the population included, so suppose if I am working in onco centers, I'm looking on the onco critical care patients. So probably this may not be of much significance to me because all my
Right.
patients will be highly immunocompromised and they may be on steroids, even high dose, 60 or
Right.
80 milligram prednisolone. So we have to look for the inclusion and exclusion criteria of the patient which have been included into the population before we extrapolate the outcomes to our population. So this is, I think I'll stop here and we'll continue discussing some more tips and bits of critically appraising the papers so that we can better accept it. I remember, I will just close by saying one sentence. I remember my old good days. One of my student comes and say that this is the case report which has been published, appears to be a good technique. Can I go and do it? I said, I will not change my clinical practice based on a single paper. Mm-hmm. And same thing is the message for my side, that looking the conclusion of a published paper, even in a good journal, is not the indication for changing your clinical practice. You need to learn the critical appraisal of the paper and just look for that whether the paper population suits to your population and the environment is suiting to your population, then you can look for that whether the outcomes are suitable. So I stop here and over to Dr. Manish Bhatt.
No, thank you, Dr. Garg. It was really an enlightening experience with respect to the PCT versus the CRP paper, which otherwise has been a common clinical fallacy which we see day in, day out. Help me in understanding, Dr. Rakesh, because many of the listeners would be the novices in the subject. So can we say on the basis of what we have gone through that PCT should ever be used as a tool to accelerate the antimicrobial therapy? Do we have any evidence?
So
No.
Based on this paper...
So I'm just trying to demystify the evidence to the bedside medicine. Yeah.
So based on this paper, the conclusion would be that PCT appears to be one of the component strategy for taking a decision on the de-escalation or stoppage.
Never for the exhalation, right? Because of the low sensitivity and specificity.
Exactly, right? Exactly.
So
and
as
number
a de-escalation.
And number two, which they mention in limitation, Dr. Arjit has mentioned it very nicely, that PCT should be considered in addition to the other biomarkers and physiological markers, in addition to your antibiogram and antibiotic policies, to take a decision with regards to start of antibiotic or stoppage of antibiotic or de-escalation of antibiotic. But it appears from this study also that PCT has some role in taking a decision. So we cannot negate totally. It has some importance in taking decisions as a part of the team of strategies where we can take some decision.
Here, I would be having a difference of opinion, because as far as the paper which I've been able to understand, when they've compared the usual group with the PCT versus the CRP, and in fact, it's one of the largest multi-centric study, which you have said. I think it's 41 centers. So 41 centers, the power of the study, the number of cases which they have taken up, to the sample size. I think almost 6,000 patients. How much?
2,700.
2,700. So despite of this fact, we are not convinced, Dr. Rakesh. What is stopping us to get convinced? Because why I'm telling you, as a physician, on daily basis, when I see, there's always a tendency, please continue this antibiotic for maybe a couple of more days. And in fact, the reason for having one of the major reasons for the antimicrobial resistance in our country is failure to stop the antibiotics. So I'm slightly perplexed. Maybe, this is something which we can discuss later on, keeping in with the interest of time. Or would you like to answer it?
I'll just finish in 2 sentences. That in critical care, there is not, in majority of situation, a single marker based on which you can take your decisions with regards to antibiotics. Same is applicable for PCT also. It has its own limitation. If you can give me a selected group of population, then we can say that, yes, probably in this patient, it has a good thing, a good decision maker thing. But if you see the whole spectrum of the critically ill patients, starting from trauma, where this acute stress-induced immunosuppressed, you talk of oncology patients, where then steroid and disease-induced suppressions. When you talk of pregnancy-related sepsis and all those things, so these are different spectrums, and we cannot say that PCT across all these spectrums should be a marker to take a decision on antibiotics. But if you say a patient who comes with COPDs and no other comorbidity with acute exacerbation, landed into some sepsis component, probably you can think of. But again, COPD is also an immunosuppressant situation. So again, it may not be the right way. But yes, the biomarkers along with your clinical decision-making tools is an important decision maker. I'm saying that PCT is an important armamentarium, but that's where we people are learning from antibiotic stewardship and antibiotic policies of the hospital decides that we should not be continuing, say, empirical antibiotics for long durations without justifying the reason.
So I think it's very nicely you have summarized, Dr. Rakesh, and thank you, Dr. Rakesh, for mentoring these 2 important sessions, and thank you, Neeraj, for both as a moderator as well as the speaker for the first session. Arijit, fantabulous presentation from your side. Love to hear from you, maybe in the next couple of sessions as well. And nevertheless, Dr. Ranveer Tyagi-ji, we are really thankful for this kind of initiative which has been taken by the ISCCM to promote the evidence-based medicine, how you can simplify to the bedside medicine. And with this, I would like to bring it to the closure. Thank you. Do we have Dr. Ranveer here? I think he's not here. So can we close the session, Neeraj, or would you like to express something?
Just one thing. I think Dr. Manish, you already explained our concept and ideas regarding this journal club, and it's yes, the brainchild is always Ranveer Tyagi sir for keeping us updated about the evidence-based medicine. I have seen lots of questions and answers and the people were from Indonesia, from I think from the Solo. There are various other international people, and they have asking few questions. I have answered my part also. So what we will do that we will try to answer them on the Facebook only, because it is on Facebook Live, so that people have that interest because their queries are very, very, I think, very interesting one. So Arijit, we will share you that questions also, because they are related to your PCT and today's topic, and I have answered my side answers from my side. And meanwhile, Rakesh sir, what you told that that critical appraiser of paper is always very, very important to make it useful for us to make it in our clinical practice. So definitely your expert opinion will be always needed for us, for sure. And this is all from my side also. And thank you, Dr. Manish, for excellently hosting the session as well. And as this was a new session for the first session, so we are hopeful that from the next session also, it will be more interesting journal clubs and journal papers will be there. Yeah, thank you.